So this 20 minutes video is going to be very helpful for you because in this video you will have a lot of knowledge on type 2 diabetes mellitus, that is the global pandemic throughout the world. So in this video you will have a great idea on diabetic mellitus. This video I have made from American Diabetic Association, European Diabetic Association, Indian Diabetic Federation and Harrison Principles of Internal Medicine 21st edition. So this video is going to be very informative for you as a first year till the final year, till intern, till any department postgraduate, till persons working at the periphery. It is a mandatory thing and it is a common responsibility of every physician to know about this disease called diabetes mellitus. In this video, we will have an idea how to deal with diabetes mellitus and what are the complications and how you should deal with the complications of diabetes mellitus. I'll be giving 3 prescriptions at the end of the video. The first question would be for a rich person. For the rich person, that is the best management present in this world for diabetes mellitus. The second prescription would be for a middle class person for all the doctors and our relatives. The third prescription would be for a poor person. And at the last I will say what are the things I write in my prescription for a diabetes mellitus patient. So these 20 minutes would be very informative for you. You can make a note of this 20 minutes also because it is going to be really helpful for you. Believe this. Hare Krishna, Hari Bol, hello everyone. So today this is the first educational video by myself, Dr. Abinash Mishra, MBBS, MD in General Medicine. So this video is all about type 2 diabetes mellitus, that is the global pandemic throughout this entire world. So as you know, India is considered as the diabetic capital of the whole world. Next to China, we have the maximum number of diabetes patients from young to adult onset. And they are like all the patients with diabetes mellitus, they're landing up with complications. So in this video, we'll know how we should diagnose a patient with diabetes mellitus, what are the investigations we need to do, and how to treat a diabetes mellitus patient. Starting with type 2 diabetes mellitus. So type 2 diabetes mellitus, like mostly obesity has a complication. Means those people who are fat, as you all know, they have a risk of insulin resistance. So these people suffer from type 2 diabetes mellitus. This is a very important point that we need to know first point number 1. So when a diabetic patient, suppose I am sitting in the outdoor or at the casualty. So if a person is coming to me, like what? History of like polydipsia and polyphagia with increased urination, that first thing that a patient is suffering from type 2 diabetes mellitus. So if you go to the Harrison Principles of Internal Medicine, we'll be knowing that all the diabetic patient, whether it be India or it be world, around 50% they suffer from many complications like that you all know, that is diabetic retinopathy. So coming to this eye part, so you must know as per the Harrison, a diabetic person has 25 times more risk of getting into blindness. So you must be very cautious. You must do a fundoscopy for every diabetic patient. That was the diabetic retinopathy. Point number 2, diabetic neuropathy. That is a tingling and numbness in the lower limb and the upper limb. That is globe and stalking type of neuropathy. So as per the Harrison, around 50% patient also, they suffer from this diabetic neuropathy. That is digital, symmetrical, progressive, polysensory motor neuropathy. So they complain of tingling and numbness. So if a patient is coming, you should first take the history of like blindness, then you should take the history of tingling and numbness in the lower limb as well as in the upper limb. The third point of view is diabetic nephropathy. Because as you all know, the most common cause of kidney disease, that is chronic kidney disease throughout the world and also in India, is type 2 diabetes mellitus. So these diabetes patients suffer from like ophthalmologic changes, that is diabetic retinopathy, diabetic neuropathy, like tingling numbness over this hand, and diabetic nephropathy. That means what? 50% patient, those who are diagnosing the patient of 50%, they are suffering from these 3 complications, that is diabetic retinopathy, neuropathy and nephropathy. So yearly diagnosis and yearly like what? Like follow for this retinopathy or neuropathy and this nephropathy will prevent the patient from getting into blindness or getting into kidney failure. So you must first take the history and send some proper test to diagnose this patient. One more disease more very like closely associated, that is metabolic syndrome. As per the prevalence of the metabolic syndrome throughout the world, 50% of the world population suffer from the metabolic syndrome. This metabolic syndrome, they has a risk of getting into diabetes mellitus. So how you should diagnose a patient of metabolic syndrome? As per the WHO guideline, if a patient is having 3 out of 5, so what are the 5 things? The point number 1 is a waist circumference of 102 in male and 88 in female. But in India, it is considered as 90 in male and 80 in female. That is a waist circumference. You have to measure the waist circumference by the help of a tape. That is the point number 1. Point number 2 is triglyceride level of more than 150. Then point number 3, blood pressure of 130 by 85. Then point number 4, then HDL of around how much? Like 50 in female, less than 50 in female and less than 40 in male. And the point number 5 is a fasting blood sugar of more than 110, or some guidelines say of more than 100. So if a patient having any 3 out of these 5 will be diagnosed as a patient of metabolic syndrome. And this metabolic syndrome has a risk factor of getting into diabetes mellitus. If you go into Wikipedia, we'll be knowing that by 2045, 134 million population of India would be affected from diabetes mellitus. We first seeing a chart from the American Diabetic Association, how we should approach a patient of diabetes mellitus. Suppose a diabetes mellitus patient has come to you from the history of like polydipsia, polyphagia, and maybe vision loss, and maybe tingling numbness, that is diabetic neuropathy. We must send some minimum test that is required. So the minimum tests are fasting blood sugar, postprandial blood sugar, HbA1c, lipid profile, LFT, RFT, and urine albumin creatine ratio. These are some of the minimum tests we need to do for a type 2 diabetes mellitus patient. So after doing different tests that I already told you, like fasting blood sugar of more than 126, postprandial blood sugar of more than 200, and HbA1c of more than 7, you have diagnosed a patient of type 2 diabetes mellitus. After diagnosing the patient of diabetes mellitus, you need to see some of the approach, how you should give a drug. So the first drug is, can you think? It is always exercise and diet. That is modified nutritional therapy and exercise are considered the key management in a patient of diabetes mellitus. As per the Harrison Principle of Internal Medicine 21st edition, HbA1c reduction of around 3 up to 3 can be done by the help of this diet and the exercise. So your management should be counseling to the patient that you go for a good diet, that is more vegetables, more fruits in diet, like fructose should be preferred over the sucrose, and low fat diet should be preferred. And as for diet plan, you give the first is diet plan. After that you go for a exercise therapy, that is aerobic exercise. 140 minutes per week exercise need to be done as per the American Diabetic Association. So approximately 25 minutes exercise in a day the patient need to do. Why exercise is this much important? Because in diabetes mellitus, there is what? Insulin resistance in everywhere. So the peripheral tissue has got a insulin resistance. So there is a GLUT4 decrease in this diabetes mellitus. So if a patient do exercise, there will be increase in GLUT4 receptors in the peripheral body, like mostly in the muscle. So as the GLUT4 receptor increases in the peripheral tissues, so glucose can be easily taken up. So that will cause a decrease in blood sugar level. So HbA1c reduction, you must remember 3. No drug can give HbA1c reduction of till 3. But this exercise and diet can make a patient like decrease HbA1c of equal to 3. You must remember this one. The first is always exercise and nutrition. Coming to the point number 2, you go for a metformin therapy. Most of the physicians start with metformin 500 mg OD or BD. That is physician choice that you can try with. You went for exercise, you went for a diet, then you went for a metformin 500 mg OD or BD. Remember not to cross the metformin dose of 2 gram. Some books take 2500, that is 2.5 gram. So you take it like 2 gram. Max to max of 2 gram of metformin need to be given. We mostly give up to 1500 milligram. So go for a metformin. After a diet therapy, after exercise therapy, you go for what? Metformin. After giving metformin, if still the patient is not controlled with the sugar, still the fasting blood sugar is more than 126, or still the postprandial blood sugar is high, and still the HbA1c is more than 7, you need to add one more drug. So this is the most important rule. Which drug you need to add? Most of the physicians, they add what? Sulfonylurea, which should not be done. The sulfonylurea should be the last resort of diabetes management as per the new guidelines. Every guideline, sulfonylurea is the last preferred segment. So what you need to start? So this is chart of American Diabetic Association. In this chart you can see in one group there is what? Cardiovascular disease, and in other group there is no heart problem. So in this cardiovascular disease group you need to add 2 drugs. That is one GLP-1 analog or SGLT2 inhibitor. These 2 drugs has got a good effect on the heart. one drug that we have got is semaglutide, that is an oral drug. Liraglutide are given like injectable, so that's why you go for a semaglutide 3 milligram, that is a GLP-1 analog. We can also go for SGLT2 inhibitor, that is considered as like the gold standard drugs in heart failure patients. Even in non-diabetic patient also, we are giving what? SGLT2 inhibitors. That is what, like empagliflozin, dapagliflozin, calagliflozin, we are giving these drugs, that is SGLT2 inhibitor. I will tell you what are the drugs, what are the dose you need to give of this SGLT2 inhibitor. So if a patient has got a cardiovascular disease affection with diabetes mellitus, you go for these two drugs, that is GLP-1 analog and also SGLT2 inhibitors. So these are the two most important drugs. And if the patient is not suffering any cardiovascular disease also, she is a normal patient, no heart involvement, still you go for this SGLT2 inhibitor or GLP-1 analog, that is semaglutide 3 milligram or SGLT2 inhibitor. I will tell you in some time. So after these two drugs has been finished, that is GLP-1 analog and SGLT2 inhibitors, we will be coming to the third drug, that is a very good drug and also a cheap drug, that is DPP-4 inhibitor. What are the DPP-4 inhibitor? That is teneligliptin, vildagliptin, saxagliptin, sitagliptin, the gliptins. You know, these are like for the average person. So this SGLT2 inhibitor and this semaglutide, these are for the rich persons. And these gliptins are made for the average, like for doctors we can afford like what? We can afford this DPP-4 inhibitors. Apart from the DPP-4 inhibitors, we can go for some of the like old drugs, that is sulfonylurea. You must remember the sulfonylurea, that should be the last resort if the patient is very poor. You can also see in this American Diabetic Association, if the patient is very very poor and cannot afford for any price, you may go for a sulfonylurea, because the sulfonylurea has got a side effect of weight gain and also have a bad effect on the heart. So sulfonylurea should never be preferred in any patient. It's a table from the Harrison where you can see we have got a HbA1c reduction of up to 3, like in diet and nutritional therapy and in also exercise therapy. So diet and exercise is the key aspect in management of a patient of diabetes mellitus. So while you approach a patient, what are the targets you need to achieve while you are treating a patient of diabetes mellitus? The targets you need to achieve are a HbA1c of less than 7. You need to do it every 3 months. And a fasting blood sugar of less than 130, postprandial blood sugar of 130/80, and blood pressure should be 140/90, less than 140/90 obviously. Young, if the patient is young, the blood pressure should be less than 30, and LDL should be less than 100, HDL should be more than 14 ml and 15 ml, and urine albumin should be less than 30. This is the most important part while you treat any patient, let it be your father, let it be your grandfather, let it be your mother, any patient, because most of us, our family members, are suffering from diabetes mellitus. So this is the most important part and most important target you need to achieve. I am repeating it again, that is the HbA1c value of less than 7, a fasting blood sugar of less than 130, and a postprandial blood sugar of 130 to 180, LDL of less than 100, and triglyceride value of less than 150. With that, one more, the most important thing is urine albumin should be less than 30. There should not be more than 30, because once you are getting albumin in urine means the kidney has got some sort of remodeling changes. The patient may go into what? Chronic kidney disease. So it should be a worrisome thing for you if your family member is affected or any patient is affected. If albumin is present means you need to worry at that time only. So now I'll be telling you how you should treat a patient with diabetes mellitus. Approach. You should remember this one very cautiously and you can also note it down. So first you started with what? You started with good diet plan, that is modified nutritional therapy. You went for exercise, that is 140 minutes per week, that is 25 minutes per day. After going to two things, we can go for what? Metformin, as I already told you, that is 500 milligram OD or BD. Metformin is considered as a goal, key therapy in a diabetic patient because it decreases the intrahepatic glucose production, decreases by this help of metformin, that you all know. That is AMK inhibitor drugs that we already know about metformin. It's very important of metformin, 500 milligram OD or BD. After starting these three drugs, if there is HbA1c of less than 7 is not achieved, first see the status of the patient. If the patient is rich, what are the drugs you need to give? So rich man's prescription is this one. This is a rich man's prescription. So rich person has come, like he's earning in lakhs. So you need to go for this therapy because this is worldwide now the best management for a diabetic patient. So RX, you write down RX, that that is type 2 diabetes mellitus, with surely the patient is suffering from complication, because already we have discussed 50% of the diabetic patient suffer from diabetes related complications, that is retinopathy and maybe like what, neuropathy and maybe nephropathy and maybe cardiac remodeling, maybe non-alcoholic fatty liver disease. So always go for this best drug therapy, that is RX first. Point number 1 is always, I have already discussed, that is exercise and modified nutritional therapy. Point number 2, you go for what? You go for tablet metformin 500 milligram OD or BD. After food you have to give. Tablet number 2 is finished. Tablet number 3, that is semaglutide. As I already told you, 3 milligram OD after food. Semaglutide is a very good drug and has also got what, weight loss reduction property. So obese patient is coming, you go for semaglutide 3 milligram. The only weak point with semaglutide is its cost is too high. The cost is, per tablet will cost you around 300 rupees. So per day the patient has to afford 300 milligram. But that is the best diabetic medication present currently in this world. That is semaglutide 3 milligram OD after food. After giving semaglutide, the fourth drug in our line is atorvastatin 10 milligram or 20 milligram OD of your choice at the evening time. As per the CARDS trial and different trials, every diabetic patient, if he is crossing a age group of 40 or 50, you must go for a statin therapy, because a diabetic patient has got remodeling throughout the body. There will be remodeling in the brain, there will be remodeling in the artery, there will be remodeling in the heart, and these statins, they has got a what, pleiotropic actions that will prevent the remodeling throughout the body. So you go for statin, that is atorvastatin 20 milligram OD at the evening time, or rosuvastatin 10 milligram OD at the evening time. After going for statin therapy, we make the patient follow up. You come after 14 days or after 1 month, and your target should be always, HbA1c should be always less than 7. That is the very important test. If as a physician you are not doing HbA1c for a diabetic patient, you are making a blunder. Like, patient should mandatorily go for HbA1c and target should be always less than 7. And before going HbA1c, we need to only check one thing, that is hemoglobin, because as the name suggests, glycosylated hemoglobin. If the hemoglobin would be low, you will get a falsely low HbA1c. So always go for hemoglobin. The hemoglobin, like it is 13 to 14, it is considered as okay. If the hemoglobin will be 9, so HbA1c will be falsely low. So you go for HbA1c, target should be less than 7, and always priorly you should check for the hemoglobin. The second group of patients are like what, average socioeconomic status patient, like all the doctors who are like what, middle class person. So a middle class person is coming who is earning like in thousands, like consider like 70,000, 80,000, who can afford a prescription. So that was the rich man's prescription. The prescription will be costing around 4,000 per month. And coming to average man's prescription, that would be costing around like 1,000, 2,000 per month. So a average person has come to you. What are the prescription you need to go? RX, point number 1, as you already discussed, nutrition and exercise. Point number 2, after nutrition and exercise, we have to go for what? Metformin 500 milligram OD or BD of your choice. The point number 3 is we should go for a SGLT2 inhibitor, that is empagliflozin or dapagliflozin. So we can go for a 10 milligram OD after food, empagliflozin or dapagliflozin. We can also go for canagliflozin 100 milligram OD after food. After doing this, we have to add what? Atorvastatin, that I already told you, atorvastatin should be given to every diabetic patient, and the LDL target should be less than 100. And if the patient has got a heart attack or coronary artery disease, the LDL level should be maintained below 70. So your target should be less than 100. To be basic principle is LDL should be always less than 100. So go for a statin mandatorily. Even if the LDL is less than 100, you go for a statin therapy, atorvastatin 10 or 20 milligram at the evening time, because that has got a pleiotropic action throughout the body. Starting more dose. So you have maintained a patient like metformin, you have given a semaglutide, or you have given a SGLT2 inhibitor, and you need to get, and still you did not achieve the HbA1c status of less than 7. Now you have to go for triple drug therapy, that is metformin 500 milligram OD or BD, then empagliflozin, dapagliflozin that you have already given. Then you can add a DPP4 inhibitor, that is tenagliptin, vildagliptin, saxagliptin. So this is a triple drug therapy, can also be tried in diabetes mellitus patient. Now coming to a lower middle class prescription. So this lower middle class prescription, this is actually, I always write this prescription. This prescription I always write, because these drugs are available in our MKCG and also in SCB. In Niramaya, the government of Odisha, Naveen Patnaik, is giving this medication free of cost in Odisha. So this is my prescription. So I first write RX. Point number 1, go for exercise and nutrition therapy. Point number 2, I go for metformin 500 milligram OD or BD of my choice after food. Then point number 3, I go for teneglyptin 20 milligram OD or BD of my choice. Because this teneglyptin is available by the Niramaya, by the government of Odisha. So I go for this teneglyptin. After giving teneglyptin, I obviously go for statin, that is atorvastatin 10 or 20 milligram OD, seeing the LDL status. And I motivate the patient to go for the exercise, and I give one more drug, that is saroglitazone 4 milligram OD. This saroglitazone is a very good drug because most of the patient, as I already discussed with you, they suffer from what? Diabetic dyslipidemia. So I go for this drug called tablet saroglitazone 4 milligram OD. And because most of the patient have diabetic neuropathy, they complain me like what? They are getting tingling and numbness throughout their body. So I go for tablet pregabalin 75 milligram at night. Because the pregabalin got some sort of sedation, I prefer it over giving over the night time. And it is also available free of cost at the Niramaya. And one more drug, that is very important drug, I always advise, that is Ramipril 2.5 milligram OD. Why I give Ramipril? Because I already told you, 50%, up to 50% patient of the diabetes mellitus, they suffer from diabetic nephropathy. So you have to go, AC inhibitor are considered the gold therapy in diabetic nephropathy. It prevents the kidney remodeling and prevent CKD. So you have to go for this drug, that is Ramipril 2.5 milligram, or you also can go for ARB, that is telmisartan also. It is available in Nirama free of cost. Coming to a poor man's drug. Poor man's drug is sulfonylurea. That is the least preferred drug in this 21st century. You should not prescribe a sulfonylurea to any patient. You must remember this one. This is the last, because that causes severe weight gain. That causes what? Like hypoglycemia. That causes what? Cardiac remodeling. So sulfonylurea should be the last resort of therapy in this era of 21st century, because we have got alternative drugs, and also these drugs are available at the Niramaya, given free of cost by the government of Odisha. We should go for this teneglyptin DPP4 inhibitor, and we should not go for this drug. But if you are going to the periphery and this teneglyptin is not available, like we are working in a CHC or a PFC, what are the drugs you need to give? So you always motivate the patient for like what? Exercise and nutrition therapy. Then you go for metformin 500 milligram OD or BD. Then you can go for a sulfonylurea. The most used sulfonylurea is glimepiride 2 milligram or 3 milligram OD. That is most commonly prescribed drug. That is what? I already told you, that is sulfonylurea is what? Like I already told you now, glimepiride. And you can also go for atorvastatin, that is 10 milligram OD at the evening time. So the investigation that you mandatorily you need to do, I already discussed you, again repeating it. Fasting blood sugar, the goal should be less than 130. Postprandial blood sugar, the goal should be 130 to 180. HbA1c goal should be less than 7, and urine albumin should always be less than 30. You have to go for a lipid profile because diabetes causes dyslipidemia, so you have to go for lipid profile. LDL should be always less than 100, TG should be less than 150, and HDL in male should be more than 40, and in female it should be more than 50. You must remember these things, and you have to also go for LFT. Why LFT? Because most of the patient of diabetic mellitus patient, they suffer with non-alcoholic fatty liver disease. That's a chronic liver disease of some sort of. So you have to also go for a LFT. And renal function test also. You need to do urea creatinine, because the patient may have got what? Kidney failure during the time of diagnosis of diabetes mellitus. Also go for what? Retinal screening, because I already told you a diabetic patient have got 25 times higher risk of getting into blindness. So this is how you should approach and target your diabetes mellitus patient. And if a patient is having postprandial high always, means you are checking, you are going for HbA1c, you are going for fasting, you are going for PPPS, and you are finding out that after eating only the patient is getting more blood sugar. So you can go for this drug. That is what I followed you, Boglibos 0.3 or 0.4 milligram TDS. Before the food you can give that drug, Boglibos. So these are drugs you need to give, and these drugs do side effects, and we will be not discussing the side effect of these drugs in this video. And you must remember, if the patient is obese, always go for what? GLP-1 analog or SGLT2 inhibitors, because these two drugs has got a good weight reduction capacity. Always obesity and diabetes are interlinked with each other. So this was all about diabetes mellitus. In this video, you learned about the diabetes mellitus. Hope this video is very, very useful to you. You can see this video 2-3 times and you will be having a good idea on diabetes mellitus. If you want to know these videos, these medical educational videos on any disease, you can let me know in the comment section. I will be making videos on this. Apart from diabetes mellitus, I am thinking to make the video on hypertension. So as a physician, as a first year medical student, as a second year, third year, fourth year, final year intern, or at any doctor like surgery or like medicine or maybe any department you are working, all the 19 subjects, you need to have a basic idea on diabetes mellitus, because most of your family members are affected with diabetes mellitus. Let not consider the patients, because your family is affected with diabetes mellitus, because this world has got a very high population of diabetes mellitus. So you as a physician, it is your duty and the responsibility to know about diabetes mellitus and approach and yearly diagnosis of the complications will have a good outcome on the patient status. So diagnose yearly, treat yearly. And if remember patient is having any complication like renal failure or HbA1c of very high, like more than 10 or more than 9, it is an indication to start insulin therapy. Insulin is also considered as a key principle in management of diabetes mellitus patient. Never hesitate to give insulin in diabetic patient. If you are thinking that drug is not working, you have added triple drug and still the treatment is not working, you always prescribe insulin, or always or refer to a medicine specialist or a endocrinologist or any diabetologist. So this is all about diabetes mellitus. Hope this video is very helpful to you. Please let me know in the comment section what are the other videos and other diseases you need to know and how to approach this. Thank you so much. Hare Krishna and Hari Bol.